welcome to Trish TV. Are you wondering what is happening legally with this COVID business, where there's health issues going on and things are different to what they used to be, and that maybe down the track there might be some legal issues where there's been conflicts of interest and care and all sorts of things like that? Well, my guest is amazing. She is a legal nurse consultant, and Kimberley is going to share with us about her experience as a legal nurse consultant. And it's not that it's someone who's consulting about nursing. She consults with lawyers to help win cases for either you possibly as a plaintiff, or perhaps for the hospital that is going to be dealing with issues that go on. Because as we come out of this next phase, then that's when the dust settles and we're going to see issues that come out of it. It's not just just a talk on COVID, but that's the one that's most pressing at the moment. It can be all sorts of things. And we're going to be right back after this. The strongest prison bars are in your head. Leaders and teams, it's time for a jailbreak. Kimberley Flood, welcome to Trish TV. It's so good to have you on.
Oh, thanks for inviting me, Trish. I've been looking forward to this.
Oh, I'm thrilled to have met you online, and that was through an American associate who does a similar work. So it's going to be great to talk to you about the Australian context. So, Kimberley, tell us about your background in nursing and how you moved into what it was that moved you into legal consulting in that field.
Sure. So I left school and started nursing. So that's what I've been doing for my entire adult life, is nursing. And my particular passion had been in rural and remote nursing. So I worked in outback New South Wales and now in rural Victoria as well, in the critical care field. But while I was in New South Wales, I moved into a clinical governance position, looking at patient safety and clinical quality. And that's where I realised I had this great love for looking at unfortunate things that happen in health, and then trying to dissect that and look at exactly what happened and why it happened, and then trying to give the patients and their family members those answers as to why things didn't happen the way they expect it to happen in health.
So tell me, okay, that's a transition though. You had an interest in things going wrong. Did you find there was it difficult, or was there some resistance to, did you make some inquiries? And because there you are as a nurse doing your nursing job, and then you're thinking, hold on a minute, wait, this shouldn't have happened, or this could have. Was it like that? Was there a particular case that tugged at your heart and you went, hang on, this is not right? How did you actually transition into probing that field as a nurse while you were still a nurse?
Yeah, so in nursing, we are always looking at how can we improve and deliver better services and outcomes for our patients, because ultimately that's what we want. And a lot of error that occurs in hospitals is human error, but also systems and processes. So we're always looking to improve our quality and improve the systems that we have in place. And so that's sort of something that I enjoy doing, is breaking that down and trying to figure out how can we improve. And that sort of moved me towards that area of in the clinical governance area and looking at outcomes for patients.
That's fabulous. So, and clearly you were in a supportive environment where you weren't considered a nuisance or a troublemaker for questioning things, because everyone wants the best for the patients, whereas people in other fields may be wanting to change and improve things and come up against resistance.
Well, we know that when there's adverse outcomes in health, we know that it's always better for the family and for the for the patients that we have good open disclosure, and that they appreciate that as soon as an incident happens, that we're open with them and we apologise for what happened. I think we need to remember that an apology isn't saying that, yes, we're at fault or we're guilty of something. We're apologising to say, look, I'm really sorry that this has happened to you, and then trying to look and explain what happens. And at the end of the day, most patients that have an adverse outcome, they don't want to see it happen to anybody else. And so quite often I found that family members and patients have been really supportive and being involved with system improvement processes so it doesn't happen to anybody else. That's mainly what they want.
I imagine when things are difficult and there is an adverse reaction, by being willing, but expressing sorrow and empathy, it would reduce the potential negative response from because you're in it together rather than having a conflict. But also, I imagine that would help reduce burnout and frustration for staff as well, because you realise, we did our best. It didn't have the outcome we expected, rather than have that defensive position of, hey, we did all we could and don't blame us kind of thing.
Yeah, that it depends, I suppose, on what the workplace culture is like. But generally, I've worked in workplace cultures where they've been supportive of reflecting and looking at what we've been doing, and supporting each other. And we know that we're not going to get it 100% right all the time. To have that ability to reflect and improve on what we're doing, that's really the main thing. And that's what's going to stop incidents from occurring in the future.
That's great. That's really good. You watch too many movies and you think, oh heck, we're all it's not we're all going to hell in a handbag. Maybe I'm watching the wrong movies. And so that's good to hear. So talk to me about you're moving into legal consulting. So you speak with lawyers. Now, do lawyers find you, or do you advertise to them and let them know what you do? Or is it possibly that patients or people who've been patients reach out to you and say, hey, this didn't go well. Do I have any options to take this a legal route? And then you might connect them with it. How does that work?
Sure. So I have a purely health background as a nurse. I don't have any legal background. So, the information that I provide is from my own knowledge and expertise as a healthcare professional. I advertise. I've got my website, which is accesslnc.com.au. I'm also on LinkedIn, and that's mainly where I make lots of my connections with lawyers to be able to say, hey, look, I'm here, I'm available, this is what I'm interested in. I'm also part of the Lex Medicus group, which lawyers get in contact with them and they find the correct expert to help with the cases that they have. And I've had a couple of lawyers approach me as well. But in terms of patients approaching me saying, hey, I don't think this is quite right, the only sort of thing that I can do really is advise them to seek assistance from a lawyer or a law firm to help them with that process.
Okay, then that's great. That's good to know. So we've got now, that is accesslnc.com.au for Australia if you're watching overseas. And what I'd like to do is show everybody your website and see and let them know a bit more about what you do. So Access LNC, here is your website, and it is mainly aimed at who looks at this website. It'd mainly be lawyers, wouldn't it? But
so mainly lawyers, yeah. So mainly in the medical negligence area of personal injury law. Okay. That's who I'm sort of targeting and who would require my my expertise as a registered nurse.
Okay, great. So if you're watching this, and you might know someone who might have suffered from medical negligence, or you don't, maybe they have, maybe they haven't, they're not sure. they could get in touch with Kimberley, who can then direct them to legal expertise. And then Kimberley provides a service of consulting and talking about providing those lawyers with the expertise regarding the medical case and the records. So you've got your medical records decoded. It's kind of like another, so is that kind of saying it's another language quite often, in the culture of the medical field, and so you're able to break it down and turn it into English for us?
Well, that's right. They do say it's like a different language. But have you ever read doctor's handwriting?
You can interpret doctor's handwriting?
That's our job every single day as a nurse, to try and decode what those doctors have written in the notes to be able to follow their orders. So I think sometimes nurses can be a bit of handwriting experts as well, to be able to figure out exactly what everybody else has written.
Good to know. It's good to know, and because you hope that the pharmacists get that right too, because they're giving you the pills that the doctors are telling them to give you.
They're good doctors handwrite experts too.
Yeah. So, and I like what you said here. Access LNC, Australia's consultant registered nurse, will help you win more cases and achieve high levels of client satisfaction. And that's what we want, is we want people to have good outcomes for what they do. And I know this is a bit of an, people think, well, why would a resilience program talk about this? Well, when your health goes, when you're not feeling good, when you've had a trauma that's a health trauma, it hangs around. There is residue that affects your life. And it takes resilience to get up again and to keep going. And when you have a support person in your corner, like Kimberley, then it takes some of that burden away, that it just eases it, so that things can go on in your head and just go, what the heck is going on? And you can think the worst. But when you have a professional that you can talk to and say, well, what about this? And Kimberley can give you that perspective. And if you are a lawyer watching this, then having someone like her can take a lot of the burden off as well, and also to support your case, because it's not just legal opinion. It's, you're not just doing it all on your own. You've got the evidence to back it up, plus the expert legal opinion to support your case, presuming your case is worth supporting. So, and Kimberley works for both sides, whether it be the plaintiff or the other side. So she is impartial. And so whoever you are, you can draw on her expertise. So that's helpful. What else would you like to cover today, Kimberley? We were having a bit of a chat beforehand.
Yeah. So I'd be happy to move on towards talking about COVID and
great
sort of the experiences that we've had here in Australia in comparison to what we've seen overseas, and the difficulties that may arise from that in future.
Yeah. So you were talking to me about the difference between, there's the issue of care, that the interruptions with the shutdowns have had issues with care, where people may actually die of things that are not COVID related because of COVID, because of those interruptions.
Right, that's correct.
And the difference between Europe and Australia in that. So talk to us about that.
Sure. So I think looking at what's happened overseas, particularly in Europe, in America, India in particular now as well, they've been so burdened by COVID, and so many of their health resources have been taken up by COVID, that I think looking at those areas in the future of law and legal cases, they'll be looking at, well, my family member died, or I've had adverse outcomes because of this, because I haven't been able to access the resources that I would expect from the health system in those countries. But having a look at Australia and the way we've handled it with lots of lockdowns, quarantines, we haven't seen the big outbreaks that have been seen elsewhere, which is excellent. But on the other side of things, the government has imposed quite strict screening criteria for every patient that presents to a hospital. And just thinking back to when COVID first started, hospitals had to make specific quarantine areas for suspected COVID patients to be cared for. And I think there was a lot of fear in the community about COVID, and we found, I believe, a sharp decline in patients presenting to hospital.
Right.
Which means that when they did finally come to hospital, they were a lot sicker than what they would have been originally, say 12 months beforehand, because they didn't want to come to hospital. They didn't want to be seen to be taking up space when there's this potential big outbreak. So that's sort of the first issue and the first thing that I've sort of really noticed. But moving on from that now, I've found that we're probably back up to our normal operating side of things, of the amount of patients that are coming through and the types of injury and illness that we see, which is good. Wow. Because people are seeking help and seeking care.
So do you
you're right.
Do you see some ramifications down the track with families taking legal action with regards to their not getting the care that their loved one, maybe not getting the sufficient care they might have got because they were, because of all the quarantining?
So I think for that delayed presentation, that's sort of their own personal responsibility for deciding when it's appropriate to come to hospital to seek medical care.
Yeah.
But moving on from that, with the quite strict screening criteria to determine whether a patient is potentially COVID or not and how they're treated, I think that's an area that I am finding quite interesting, because a patient might present with, say, they've had a heart attack, and common symptoms of a heart attack is that you get short of breath. Well, because you've mentioned that you're short of breath, you've now fit criteria for being a potential COVID patient, even though we've got clear evidence that, there's changes on the ECG, which show that there's been a heart attack. There's a particular enzyme which is found in patients which have a heart attack, and that's elevated, so we know that they've had a heart attack. And yet we've still been required to treat them like they're a suspected COVID patient until we have a clear negative swab from that, which in the cities I think has not been too bad, because the testing facilities are all there in the cities. So you can have your swab results back within a matter of a few hours. But I know rurally we don't have the capability to be able to send it down to the local lab, have it tested and go, oh, okay, they're COVID negative.
Wow.
So there's been times where patients have been put in isolation as suspected COVID patients, because we've had to wait 2, 3, 4, 5 days for a test result to come back to say they're negative, despite having clear evidence of what is exactly wrong with them. And if you don't mind, Trish, I'll just go through what it's like for a patient to be in quarantine.
Yes.
Just so that people get a good understanding of what happens. So basically, what's supposed to happen when there's an airborne, which is what COVID is, it's an airborne infection, should go into a room, negative pressure room. The staff will get all their PPE on, so they'll have their a special mask on, their gown, gloves, hair nets, eye protection, and when we put all of that gear on, we have to have somebody be our PPE spotter, they're called. So they've got to check to make sure that we put it all on correctly, because if we don't put it on in the right sequence, we're at risk to contaminating ourselves with COVID, and then or anything else, influenza. It's the same process. That takes quite a bit of time to be able to get in and go see the patient in the room. There's also been concerns available to us, and we've seen overseas where hospitals have run out of PPE for staff. So when we've got a patient in quarantine, we generally like to do cluster care. So we will get everything we need for, say, that hour, bundle it up, take it in, so might do observations, give medications, bring food in, all that sort of stuff. And then we're not popping in like we normally would with other patients and ducking our head in and going, hey, is everything okay? How are you? So it could be a good half hour, maybe even more, before they see another health practitioner, whether it be nursing, allied health, medical. And deterioration can happen quite quickly when patients are sick. And there is that potential there that there is misdeterioration or there's delays in care because of the time it takes for us to put our PPE on to go in, or because we're trying to do cluster cares to minimise our interactions with that particularly infected patient or potentially infected patient.
Wow, that's gosh, that's so interesting. I had visuals of someone covered in PPE. You know, someone needs care desperately, and it's like, well, we can't go in yet. We've got to get all our gear on and get that happening, and it can be quite cumbersome. I mean, it's hard enough to remember to put your mask on to go into the shopping centre, and it's uncomfortable. And I know, and as a churchgoer, when we were able to, but we still had to wear masks, then, you know, the singing, you can't, you know, singing with a mask on, it's like, oh, I think I'll just mouth the words because my breath is just, when you're singing, it just falls. So I can't imagine how much harder it must be. I mean, you'd probably have better quality PPE than what, you know, Joe Public gets to use, but I imagine it's still quite uncomfortable. But wow, you know, you have our deepest gratitude and admiration. And if you're watching as we go, either live or later on, then feel free to pop in a comment. If you're watching live, if you've got a question for Kimberley, then pop it in and we'll bring it up and address it. And also, while you're there, please like and share and tag people that may be interested in this recording. It's just so interesting to get behind the scenes, Kimberley. It's just great.
So Trish, I'd like to just on the other side, on the other side of the quarantine wall, I'd also like people to try and think about what it would be like to be the patient as well. You're sick, you're in hospital, you're very vulnerable. You probably don't really know what's going on and you're scared. Plus you're put in a single room. Plus you've got people that you can't really see their faces and you've got no actual human contact and touch. And I think we've started to realise now how important it is for humans to have touch, to be able to hug, hold hands, and then to not be able to have any family members or friends come and visit you and be there with you and support you makes it so difficult. And then you don't have COVID. So you kind of feel like you go through all of that because you might have something. And I understand why people feel like, you know, that they're being treated in a particular way and how distressing and upsetting that can be. How as clinicians we need to be mindful of that and the extra stress that we're placing on our patients because of it too.
So distressing. And we've had so many stories of people who are actually dying in hospital and their loved ones desperately want to visit them and they're just unable to. And we've had some really hard rules around that. And I think, you know, and it's supposed to be on a case-by-case basis, but then the variables of which cases get through and which don't seem to be about whether or not you can get a current affair involved, you know, to push it for you. Just so sad. You know, the friend of mine in America who declined to come on the show, who runs a hospital ward, and she said, Trish, I don't want people getting in touch with me about it, but the controversy in America over getting funding regarding COVID cases. And she said, look, you know, when we're taking on extra COVID patients, yes, we got funded, and that it was necessary, and there was funding based on COVID cases. However, people could present with cancer that's terminal, and they get COVID, and they die of the cancer, and the COVID accelerated it, but they still died of cancer, but the death certificates might say COVID because that gets the hospital funding, or however I'm wording that. But there's a controversy that, but if their death certificate says COVID, then the life insurance policy is void for a lot of people. And she could see a lot of, now she's not a legal nurse, she runs a pathology department. And she's like, look, Trish, I just have to get on with the job and serve my people. And so she was, I said, oh, will you come and talk about that? She said, no, I don't want people contacting me and saying, hey, what about this? So I went, okay, I'll talk to Kimberley. But, now, could that possibly happen with Australian cases, or is our system a little different?
So our health system is quite different to how America is run, because we've got Medicare and the government sort of funds our hospitals, whereas in America they're generally privately owned. In terms of how death certificates are written out, if I would say if a patient, say for your example, had cancer and then they got COVID and that accelerated the death, their primary cause of death would be written as COVID, but then I suppose the other causes. So there's multiple sort of lines on a death certificate. So the main cause would be COVID, and then it would be the cancer next, and then anything else which has gone from that, or any other health problem. So if they've got diabetes, which is a big problem, or if they've got lung disease, which is a problem, that will also be listed as sort of secondary causes of that patient declining and then passing away.
Wow.
On a death certificate, not very often is there just one cause of death, because we know that there's multiple things that lead to a patient to die.
Wow. Okay. Well, I guess it'll be in the next few years that these things unfold, and where you're going to be a very busy lady with your consulting for these cases. So
yes, which is a bit sad, really, because we don't want to see these things happen to people.
No, we don't. But when things do happen, it's good to know that there are experts out there who can help us navigate our way through them. Kimberley Flood, my goodness, thank you so much for bringing your insight to Trish TV and being a resource for people, for lawyers, for things coming through. So, we're not out of the woods with COVID. It is still full on and raging, and it might be declining in some areas, but the legal ramifications are yet to be explored. So thank you for being someone who will be a great resource in the next couple of years as it unfolds.
No worries. All I can say is watch this space, I think.
I think so. All right, Kimberley Flood, everybody. And catch you next time. And we will, next week we will have another show, but this one has been great. If you've liked it, if you've enjoyed it, please like, comment, share it, tag someone, particularly in the legal field, because Kimberley might be just the person that they're going to need for their assistance. All right then. See you later.